This topic is fetal well-being. Fetal well-being is the health and viability of a fetus during gestation. Throughout gestation, the healthcare team monitors fetal growth and development, which includes the fetus's size, weight, limb measurements, and movement. With this routine monitoring, the healthcare team can detect any fetal anomalies early. This allows for diagnosis and early intervention to either correct these anomalies or prepare the pregnant client for the fetus's care following birth. In the image, you can see the expected growth of the fetus throughout gestation. The pink bar lines indicate when certain body structures are developing and when they are the most sensitive to structural and functional anomalies. The second trimester ultrasound is typically performed at 20 to 22 weeks gestation. You can see an example here. In the ultrasound images, the bones and other dense structures appear white. Tissues appear gray, and amniotic fluid appears black. This has many benefits. It allows visualization of the number of fetuses, and if there are more than one, like with twins or triplets. The team can see if the organs and structures are growing as expected, and they are able to perform measurements in terms of size and shape of the fetus, allowing for calculation of the gestational age. During the second trimester, the volume of the amniotic fluid is large relative to the size of the fetus. This allows for great visualization of fetal anatomy. The fetus's cardiac activity, umbilical cord growth, and placenta location can be seen in great detail. Fetal movement monitoring is a simple way to monitor fetal well-being. Movement of the fetus's body and limbs requires higher function of the central nervous system. So measuring the number of fetal movements in a set period of time can provide reassurance of normal fetal growth and CNS function. Expectant mothers can begin daily monitoring starting at 28 weeks of gestation, when the fetus is the most active. There are two methods for monitoring fetal movement: the Cardiff count to 10 and daily fetal movement record. Vigorous fetal movement can be an indication of fetal well-being. If the number of counted fetal movements is lower than expected, this may be an indication that the fetus is attempting to conserve oxygen by decreasing their activity. The need to conserve oxygen could be due to decreased fetal perfusion and oxygenation, and the pregnant client should call the healthcare provider. A lack of movement may be benign. It just may mean the fetus is moving less because of the normal fetal sleep cycle. However, the healthcare provider may order a non-stress test, or NST, for further assessment to make sure the fetus is receiving adequate oxygen. We'll talk more about the NST later. There are cases in which a decrease in fetal movement may be ominous, meaning the fetal perfusion has decreased from placental insufficiency. This can lead to complications like preterm birth, fetal asphyxia from lack of oxygen, and fetal death. Fetal heart rate, or FHR monitoring, can be used before or during labor to monitor if the fetus is receiving adequate oxygen. The range for normal baseline FHR is between 110 and 160 beats per minute. Less than 110 is fetal bradycardia, possibly from hypoxia or umbilical cord compression. And more than 160 beats is fetal tachycardia, from fever, distress, or asphyxia. As we can see in the image on this slide, the FHR may have a normal, moderate variability from the baseline of 5 to 25 beats per minute. Absent or minimal variability shows no change or little change from the FHR baseline. This may be caused by something benign, such as normal fetal sleep cycle or fetal prematurity, or from something more concerning, like CNS depressants ingested by the maternal client, like alcohol or narcotics. Or it could indicate fetal tissue hypoxia. Marked variability or a difference greater than 25 beats per minute from the baseline may indicate fetal distress and requires further monitoring to determine the cause of such a large fluctuation in fetal heart rate. Decelerations or decreases in the FHR with a return to baseline are not considered to be a normal finding, but early decelerations may be considered normal. Let's take a closer look at decelerations. Fetal heart rate decelerations indicate a slowing of the fetus heart rate from the baseline and could indicate possible fetal tissue hypoxia. We can use the mnemonic veal chop and the image on this slide to help us understand this more. Veal is the timing of the deceleration and stands for variable, early, absent, or late. CHOP is the reason and stands for cord compression, head compression, OK, or uteroplacental insufficiency. Now let's break that down even more. Variable decelerations, as seen in the bottom part of the image, can occur during uterine contraction, but are not necessarily associated with them. They typically last less than 30 seconds from the onset of the deceleration to the trough or nadir, which is the lowest point the heart rate reaches during the deceleration. You can see that in the image. Variable decelerations are an indication of umbilical cord compression or cord prolapse. Early decelerations are an indication of fetal head compression and occur symmetric to the uterine contractions. They can be part of a normal tracing. They last greater than or equal to 30 seconds from onset to nadir, with the nadir of the deceleration corresponding with the peak of the contraction. You can see that in the top of the image, where the dip of the FHR matches the peak in the maternal contraction tracing. Absent decelerations are okay and considered a normal finding. Late decelerations are an indication of uteroplacental insufficiency, which can result in fetal death without immediate action. Late decelerations are delayed compared to the contraction. You can see that in the middle image. The contraction occurs and then the deceleration occurs. They last greater than or equal to 30 seconds, with the nadir of the deceleration occurring after the peak of the contraction. To prevent complications from decelerations, nursing interventions focus on increasing fetal tissue oxygenation. How can we get more oxygen to the fetus? Discontinue uterotonics. Is the fetus not tolerating the contractions? Then let's stop those contractions. Repositioning the client laterally, preferably left lateral, to increase maternal venous blood return to the heart. IV fluid bolus to increase circulating fluid volume. And providing oxygen if maternal hypoxia is present. And notifying the healthcare provider to anticipate prompt delivery should other interventions fail to correct the decelerations. This could include operative vaginal delivery with a vacuum or cesarean birth. A non-stress test, or NST, may be performed after 30 to 32 weeks and is dependent upon the maturity of the CNS of the fetus. Up to that point, the parasympathetic and sympathetic nervous systems are not developed enough for this assessment. NSTs are indicated for high-risk pregnancies, like if the maternal client has preeclampsia or diabetes mellitus. It helps determine fetal status in reference to CNS development and helps to verify appropriate uteroplacental function and fetal tissue oxygenation. They are also normally ordered when the maternal client counts less fetal movements during their monitoring. The NST uses an external fetal monitor for the FHR and a tocodynamometer, which monitors the uterine contractions. This helps to observe accelerations of fetal heart rate with fetal movement over a 20 to 40 minute time period. An NST is assessed to be reactive or non-reactive. A normal or reactive NST is when 2 or more fetal heart accelerations are observed within 20 minutes. You can see an example of this in the image here. The accelerations must rise 15 beats above the baseline and last 15 seconds in duration. It is important to note that the test is still considered normal with or without maternal perception of fetal movement, which can help reassure the pregnant client that the fetus is healthy. An NST is abnormal or non-reactive when there are less than 2 fetal heart rate accelerations over 40 minutes. You can see that in the image. There are no accelerations. For a non-reactive NST, further evaluation is necessary to determine the current status of the fetus. This may include completing a biophysical profile and undergoing a contraction stress test, which involves measuring fetal heart rate in the presence of spontaneous or induced uterine contractions. Completion of a biophysical profile is indicated when there is decreased fetal movement, a non-reactive NST, or for high-risk pregnancies. It assesses 5 different features of the fetus and the fetal environment. It includes an NST, looking at those fetal heart rate accelerations, and using ultrasound to assess amniotic fluid volume, fetal movements, fetal tone, looking at extremity extension and flexion, and fetal breathing. Each component is either given a score of 2 for normal or 0 for abnormal. Once all components have been given a score, they are added together to determine fetal status. A score of 4 or less demonstrates fetal hypoxia is present and that prompt delivery is indicated. A score of 6 is equivocal or ambiguous. There may be fetal hypoxia present depending upon which factors are normal or abnormal, so a repeat test may be needed. A score of 8 or greater without abnormal amniotic fluid measurement indicates normal fetal well-being and suggests the fetus is well oxygenated. To ensure the fetus stays well oxygenated during gestation, testing may be repeated until birth. The Amniotic Fluid Index, or AFI, measures the amount of amniotic fluid in relation to the size of the fetus and uterus. It is an indirect measure of uteroplacental function because decreased perfusion from the placenta to the fetus results in decreased fetal renal blood flow. This results in decreased fetal urination and a decrease in amniotic fluid volume, known as oligohydramnios, which you can see in this image. True oligohydramnios occurs when the AFI is less than 5 centimeters. It may be caused by preeclampsia or uteroplacental insufficiency. Polyhydramnios, or excessive amniotic fluid, occurs when the AFI is greater than or equal to 24 centimeters. It often results from a reduction or decrease in fetal swallowing, which happens during fetal breathing, resulting in accumulation of amniotic fluid within the uterus. It may be caused by esophageal atresia or congenital infection. Amniocentesis, which we can see in the image, is another assessment tool. This is normally done after 15 weeks gestation to decrease the risk for complications. A sample of amniotic fluid is obtained by inserting a needle into the amniotic sac under ultrasound guidance and then aspirating amniotic fluid into a syringe. Fetal cells within the amniotic fluid can then undergo genetic testing to determine fetal sex and test for a number of different genetic conditions. An amniocentesis is indicated for clients age 35 or greater. This is when the risk of fetal genetic abnormalities increases. It's also indicated if previous children have birth defects. If the parents are genetic disorder carriers with Tay-Sachs disease or sickle cell anemia, or when there is a known genetic condition or congenital abnormality, like neural tube defects. Before undergoing amniocentesis, clients should be made aware of the complications, which include rupture of membranes, fetal loss, and infection, all of which may occur from the insertion of the needle into the amniotic sac. And introduction of fetal cells into the pregnant client may result in increased Rh isoimmunization, where the Rh negative client develops antibodies against the fetus's Rh positive antibodies. Keep up the good work. I'm proud of you.